Hello students, we will discuss briefly a case as a case discussion, which is very commonly seen, so that we should just order it is seen. It is so we can identify it very easily. So just see what exactly it is. So what is the possible diagnosis? Let's see this photo. So what are the possibilities? You got ulcerative lesion there in the left groin, probably of 3 to 4 months duration, and no other area lesions are there, entire body. You present the swelling, initially painless, eventually pain is started presenting, then started giving way, formed an ulcer with the discharge, with the blood and slough. So what is the possible diagnosis? Just think. So differential diagnosis is fungating secondaries in inguinal lymph nodes. So the first thing you have to see the groin area, inguinal lymph nodes are there. Below the inguinal ligament, you can see the inguinal lymph nodes. So inguinal lymph nodes are superficial and deep, superficial, vertical and horizontal. It's mainly in the horizontal group, like this horizontal group. This is the vertical, and here horizontal group. And fungate, this is the first thing you have to remember. Second thing, other thing is soft tissue sarcoma, which is fungating. It is also possible. So you have to remember that differential diagnosis. Third thing is amelanotic melanoma. Again, short duration, aggressive, ulcerative, initially swelling. This is also possibly you have to think of. So what relevant examination should be done? Examine limbs for primary, because it is a vertical group of inguinal lymph nodes. And so for primary, maybe small melanoma or squamous cell carcinoma or other malignancy. So examine limb for primary. Distal pulse is important, which this lesion is quite big, may be infiltrating, and so may invade the femoral artery and femoral vein. So if femoral vein compression may cause edema, venous edema of the lower limb, distal to the lesion, and artery compression or infiltration may cause feeble pulse, poor circulation in the little artery. So dorsal spinatus artery pulsation, posterior tibial, orbital artery pulsation should be checked in this patient. Compared to opposite side, opposite inguinal region also should examine, and examine proximal nodes, opposite side, other regional nodes also. Opposite side inguinal region you have to examine. Then proximal nodes means iliac nodes. If there is a groin node, inguinal nodes, iliac nodes have to be examined, because it is above and medial to the inguinal ligament. Because iliac vein goes like this, then common iliac vein, then IVC. So all these, most of the nodes are named after vein, not after artery. So vein medially goes like this. So it is above and medial, not lateral. Laterally nodes are there, circumflex nodes, other nodes are there. But iliac nodes are above and medial. So examine for that. That gives the idea about the severity of the disease and extent of the disease as such. So always examine the iliac nodes, opposite side, other region nodes, paraortic nodes, axillary nodes, neck nodes, and so on. So you have to examine. Suppose if you think of lymphoma, fungating lymphoma, not common, but NHL can fungate. So non-Hodgkin's lymphoma can fungate. So that also you have to think of it. So other regional lymph nodes have to be examined. Opposite side, other regional nodes, examine the chest and spine. Suppose again it is a lymphoma or other malignancy, melanoma like spread may spread to the chest, lungs may spread to the brain, may spread to the spine, bone also. So you have to examine as a whole entirely. Every system has to be examined. And local infiltration also you have to look for, pulse and edema. And limb movement also you have to check. So all these clinical examination has to be done in this patient once you see this patient. And examination again, and look at the on inspection, everted margin is, the everted edge is there. Margin is well defined and regular, and surrounding area swelling is there. And discharge is there, fluid contains slough, and some proliferation area in the lower part is seen. Here in this area, some proliferation area is seen, and see the swelling here, big one, and mobility has to be checked, and whether it is infiltrating deeper pain or not. Mobility against resistance, muscle comes there, anterior muscle, so flex the limb and see against resistance whether it is fixed to that. Mostly it looks like a infiltrate into the vessels. That also has to be checked. So check the mobility in two directions, check the fixity, whether vessels are in or not. All those things are quite important to check and examine in this patient, keeping all these things as a differential diagnosis. So how to manage? Do ultrasound of the area, do ultrasound of the abdomen. So initial screening. Then eventually CCT of the area, abdomen, chest has to be done. And wedge biopsy. You take the biopsy from this area. Wedge biopsy. At least 2 biopsy to take. Normal area and adjacent area. Diagonally opposite area you have to take always. That is the meaning of the wedge biopsy from the wedge. And vascular Doppler of the limb. Vascular I said because both arterial and venous Doppler you have to assess. So venous part you have to assess. So we have to do vascular Doppler. Primary to be found. So evaluate for the primary. Examine the limb, examine scrotum, examine perineum, examine penis. There may be small lesion. Examine anal canal, and small melanoma, primary, which is clinically not presenting at all. Silent primary, that is not uncommon. So you have to examine perineum. It's a very common area. Where small primary will be there, it is not identified the patient or by you. So clinically careful examination of the drainage area is very, very important. Primary to be found out, that's very, very important. Otherwise we'll miss the primary. Disease staging should be done once you have primary, found out the primary. And as such, whatever the type, it is advanced stage because such a fungating large lesion, definitely advanced stage. So whatever the type, initially you give a new adjuvant therapy, probably chemotherapy plus radiotherapy, usually after 3 to 4 cycles. Reassess the patient, may have to do a PET CT in this patient, and PET CT how exactly looks like. If it is only locally contained tumor, then you go for the wide local excision and reconstruction of the area. Of course, during follow-up again you have to give a chemotherapy and further radiotherapy if required, and regular follow-up with the clinical examination and systemic examination, lungs, abdomen, and if needed PET CT, depending on the final histological biopsy report and staging of the tumor as such. It's a very common entity, remember students, a good clinical entity. So that is what you have to discuss, you have to approach to a patient like this. So remember my clinical methods in surgery, surgical SRB, Manual of Surgery 7th edition, operative surgery, Atlas, and Diginor, which everything is in detail discussed as a lecture. Around 220 lectures are there. You can always go through these, my books. Clinical surgery contains videos of each clinical examination. Textbook contains in detail about surgical principles, operative surgery and technique. And Diginor gives all lectures of everything. So you can go through these things for further reference. And also go through my website, Surgical Insights, for other different lectures as such. Thank you very much. So students, hope you have understood the lecture very well.